So this is an area of medicine, psychiatry, which has been problematic for a long time. Lots of terms have been used to try to capture what's going on with this sort of broad and slightly diverse group of patients who have overlapping symptoms and overlapping difficulties. And these terms, as you can see from the terms here, like neurotic and hysterical, and these words sadly become pejorative over time, which reflects partly the sort of stigma that goes with mental illness, and partly for this particular group of patients, the propensity of people to be quite dismissive of their problems. So what we're talking about is a kind of, either we might say a single umbrella kind of illness, or a group of illnesses which are characterized by mood changes, dominantly anxiety with some lowness of mood or sadness, typically mixed together, with a range of physical symptoms, aches, pains, fatigue. These symptoms, the mental symptoms, particularly the mood symptoms, and the physical symptoms, are characteristically changeable. They change in the short term, so that through the day or over a few days, the individual symptoms fluctuate, and one may be prominent on one day and another one on the next. And then they change in a more diverse way over the longer term, so that people who may be described and given the diagnosis of one of these illnesses, like a generalized anxiety disorder, may later be given another diagnosis like agoraphobia or chronic fatigue syndrome. It change over time, both in the short and the long term. And these changes, in particular, are triggered characteristically by stress or stressors of different kinds. There's a wide, diverse range of stressors. So what are we talking about then? Here are some modern terms for these sorts of illnesses that I'm referring to this morning. I've put them in the big dark green circle because they, as I say, could be viewed as one kind of cluster with people moving between these different diagnoses. Now, one of the things to say here is that some of you might look at this and think, well, I've kind of lumped together mental illnesses like anorexia or generalized anxiety disorder, and physical illnesses like irritable bowel syndrome and fibromyalgia. But that's because they share symptomatology and people move between these. And one of the problems in this area is that some people very much resent having a kind of mental health or mental illness kind of label. So they want to have a physical illness label. They want their illness to be physical because that, they believe, and lots of people around us believe, makes it real in a way that isn't true if somehow it's under psychiatry. So they want to have chronic fatigue syndrome because that, they believe, is a physical and therefore a real thing. Or they want to have fibromyalgia because it's got these real pains in your muscles and joints and so on. And that is something that's supposed to be there for a proper illness, unlike, say depression or agoraphobia. So we encounter this kind of division, this very unhelpful, and I'd say unbiblical division. And so here's, I'll just give you a couple of quotes to try and capture this. So the historian in his book Mad Travellers, Ian Hacking, wrote, we're besieged by mental illnesses, so he, like me, he's regarding them as one thing, which are more neurotic than psychotic, and I'll be dealing with psychosis later. And we wonder then, we're trying to understand them. Are they affectations? Are they cultural artifacts? Clinician-enhanced, copycat syndromes? And which ones, as we briefly and obscurely put it, are real? We're profoundly confused by an entire group of mental disorders feeling that the symptoms are both nurtured, in a sense fake, made up, and natural. They're both moral or immoral because people are faking it, or neurological, real, physical brain disorders. Or the past president of the Royal College of Psychiatrists, Simon Vesely, who's written a lot on this and very helpfully. And he said the commonest dialectic today for these kind of conditions we're talking about is they must be physical illnesses. Not because of the evidence, which remains inconclusive, but because psychological illnesses are unreal, malingered, or imaginary. This tendency of those committed to an exclusively organic view of such illnesses is to juxtapose psychiatric and imaginary. And these are the kind of problems that we deal with in this area, this division of physical and mental in a very unhelpful and I'd say unbiblical split. And then with that mental isn't real. Mental doesn't really count. To be ill, you have to have something physical. And this, of course, very much fits in, doesn't it, with the society, the culture we live in, which is strongly materialistic. And for many, particularly in the kind of areas of science I work in, denies the existence of the soul and the spirit world at all. So all illness, as far as many in our society is concerned, is physical. There is no such thing as mental, and mental, when it's used, is essentially used as a metaphor, not to refer to something that affects something beyond the physical realm. So the historian Edward Shorter, professor in Canada, Toronto, in his book History of Clinical Psychiatry, wrote, unfortunately, there's a large market for somatic, physical labels for illnesses. It is in the late 20th and early 21st century. Beliefs in allergies, insidious environmental toxins, occult viral infections, immune dysfunctions became very common in the last 3 decades of the 20th century. Many individuals become convinced that they're experiencing the symptoms of chronic fatigue syndrome, myalgic encephalomyelitis, 20th century disease, fibromyalgia, yeast hypersensitivity, Lyme disease, and many others. And the point, you see, is that you have to have some kind of mysterious viral infection. You have to have some kind of reaction to some allergy out there. And that makes it legitimate. Your fatigue, your inability to concentrate, and your difficulties to cope are legitimate because they can be attributed to a mystery virus. Or not necessarily a mystery virus. I mean, long COVID is obviously relevant here. The impact of real illnesses lasting beyond the impact directly of the virus on the body because of the larger impact on the whole person in long COVID. Long COVID, to those of us in medicine, is fairly obvious. We know that there are post-viral fatigue syndromes. And many with chronic fatigue syndrome, I think, would fit in that category. It's not in saying all this. I'm not denying the physicality of what these people have. It is simply that trying to understand it in solely physical terms is not the right approach and not a helpful approach for those suffering from these illnesses. They have real illnesses, which have real pains and fatigue and so on, real physical symptoms as well as real mental symptoms. But conceptualizing these illnesses in purely physical terms is actually really unhelpful to the people who suffer from them. All illness is not physical. But this is then one of the views in our society. All illness then, in this concept, in the materialistic worldview that we inhabit, all illness must be physical. And mental illnesses that I deal with as a psychiatrist are really all brain diseases, if you like, and we just speak of them as mental in that metaphorical way, just because we kind of find it a shorthand that's useful, etc., not because we think that there really is something beyond the physical. Or sometimes then there is this split. Again, sometimes when people make this split and they have mental illnesses and physical illnesses, then again the mental side is just essentially meant metaphorically. And this is, people would mean, yeah, they're mental, that's just a helpful way of compartmentalizing this, but they're not really different, they're all physical really. But for others then who would recognize that there is more to us than our bodies, then they might recognize that yes, there can be diseases, damage to our minds, that is our spirit, souls, that leads to then these symptoms, but they still separate them. They dichotomize them from physical illnesses. Whereas, of course, we are psychosomatic beings. And therefore, as Christians of all people, we should recognize that all the illnesses that we suffer are both physical and mental. All illnesses are psychosomatic. So physical illnesses, as they often described, will always have a mental component. Heart disease, asthma, hypertension, these physical illnesses, so-called, have mental elements to them. They have psychiatric input, if you like, or features. They're not purely physical illnesses. They're dominantly physical illnesses, and they're best treated in dominantly physical ways, because that's mainly what they are. But it's been well recognized that stress, anxiety, that we'll be dealing with later, worsens all these conditions. There is the impact of the mind on the body because we're psychosomatic beings. And then on the other hand, we have illnesses that are essentially mental. So schizophrenia, for example, that we'll talk about later, is essentially a mental illness because the dominant features that need treating are mental symptoms in the mind. But again, it has well-recognized physical features, impacts that you can measure in the body because we're psychosomatic wholes. And the illnesses that we're talking about this morning, this part of the morning, these psychosomatic illnesses, very much have in the middle, if you like, they have a lot of both physical and mental symptoms that mix together and need to be understood then in that way. Because then we are, as I said, psychosomatic wholes. We are created body and spirit or mind. This is who we are as we live here on earth and in heaven eventually. We're not meant to be separated. We will be if the Lord doesn't return. We will be for a while in heaven, but that's not a normal state. Our normal state is to be physical and mental beings interacting together. So these psychosomatic illnesses are very much then at the heart of this interaction of the body and the mind. So one of the issues then that I've focused on so far in dealing and thinking through these sorts of illnesses is this unhelpful split of body and spirit or mind, and the tendency in our materialistic society to think in terms of purely physical, rather than a biblical approach of thinking of these things psychosomatically. They're real illnesses. They're real illnesses that are best understood because we need to deal with both components. And neglect of the mental components of psychosomatic illnesses is a real problem, because it means you're never going to help these people and sort them out properly unless you recognize what's going on. But there's another set of problems related to these psychosomatic illnesses, and this is to do with the moral. I keep in my head having that phrase, the moral dimension, and then I can't forget Yesminster and the way it was used in that series, of moral dimension. But there's some moral components, and there's two related moral components. So one is personal responsibility. Now, I used this slide when I spoke last December, this quote from Andrew Sims about personal responsibility. I've just brought it back here to emphasize then that people with mental illnesses are normally responsible for their behavior. They're ill, and so we have compassion on them because they're ill and they're struggling. But nonetheless, they remain responsible for their behavior. And this is certainly true of these people with psychosomatic illnesses. So if a woman has agoraphobia and she's distressed and struggling, that when she loses a temper and shouts at the children, that is sin. It isn't, you can't excuse it by saying, well, she's having a hard time because she's got her agoraphobia and it's flaring up at the moment. She is having a hard time, and we sympathize with that. We want to support her with that, but at the same time, we don't allow her to say, well, therefore my sin doesn't kind of count at the moment. So these people are responsible, as we're all responsible when we're ill, apart from very rare situations, or essentially, as I said last time, with severe psychosis and dementia. But apart from those situations, we're responsible for our behavior. But one of the problems here is that there is a tendency for people with these illnesses to kind of say, I'm depressed and anxious and I'm struggling. And so, you pastor, you can't come along and kind of discipline me. You can't come along and tell me that I'm doing wrong because I'm ill. I've got chronic fatigue syndrome, and it's not my fault that I behave like this. Well, yes, you have chronic fatigue syndrome. We want to help you with that, but you are still responsible for that behavior. But then there's another moral element, and that is something that I touched on earlier on, and that's to do with how these illnesses, if you like, are caused or generated. And you remember the language earlier of being affectations, or of being fakes, of symptoms being malingered or made up. Okay, so we'll come to that now. So mental illness, again, a slide I used last time. So mental illness is this sort of set of behavioral symptoms, signs, symptoms that we recognize in people, and it results from something, a cause, that may be physiological, genetic within us. It may be stressors, for this talk especially, outside of us. So external causes, stressors, precipitate these illnesses, these episodes of illness in these people. So these signs, these things may be physical, may be psychological, and they lead to impairments. These people struggle with their everyday lives because of these illnesses. And then at the end, as the caveat that we always have, they're not political and religious and so on. And I went over that last time. So illnesses, like psychosomatic illness, in these cases, they're generated, they're caused by stress. And so they're essentially stress-related illnesses. Now, stress impacts on other illnesses. I've mentioned heart disease and asthma, for example, earlier on. So-called physical illnesses are certainly worsened by significant stress. But these individuals with these illnesses, they're particularly vulnerable to stress. By the way the Lord has made people, we all differ in our vulnerability. And some people are more vulnerable than others and more easily tipped over into these signs and symptoms and thus into these illnesses. Some people, we may use the language of strong and weak, and it's difficult to find the words for these because I don't mean this in a pejorative sense. You know how Paul in a slightly different context, in his letters he talks about the strong and the weak, and he doesn't mean superior and inferior or better and worse. He's just trying to capture the way that we are different people with different strengths and weaknesses. So some people are more prone, more vulnerable to decompensating under stress. And these people are the ones who are prone then to getting these kinds of fluctuating psychosomatic illnesses. And so different people have different breaking points. They tip over into these illnesses at different points. And this is further complicated by, there's actually a book that Edward Shorter wrote called From Paralysis to Fatigue, because the way in which people manifest the symptoms is affected by the society in which we live. And because of that, some people tend to think, well, that makes them kind of faked. You're making it up because in these ways, that's how we express it. No, it isn't like that. This isn't kind of consciously fake, but we are influenced in all sorts of ways by the society in which we live. That's how we talk. The expressions we use, the way we speak of things is affected by our culture in all sorts of ways. So, shell shock. So, in the First World War, then people were shocked, particularly in the armies, by this phenomenon of shell shock. So an Oxford professor of medicine, I quote this in my book, it's from Ben Shepherd's book well worth reading called The War of Nerves. He said, this professor, I wish you could be here in this orgy of neurosis and psychosis and gaits and paralyses. I cannot imagine what has got into the central nervous system of the men. Historical dumbness, deafness, blindness, anesthesia galore. So here were, soldiers, strong men, young men, signing up to fight in the First World War. And yet they developed these very extreme, if you like, symptoms. They became paralyzed. Now, when you examined them, the nerves in their legs worked perfectly well, but they couldn't walk. And this was psychological. This was mental. This was a stress reaction to the horrific experiences they were going through in the trenches and in other situations in the war. They became blind. If you tested their eyesight, it seemed that their eyes and the brain at the back of that all worked. They could see, and yet they couldn't see. They were said to have hysterical blindness, but it was a stress reaction to what they were going through. So people had these extreme, if you like, physical manifestations of stress. Now, the shock here wasn't that people under stress could suddenly not be able to walk, when in fact the nerves and the muscles and the legs seem perfectly fine physically. I've seen patients like this myself. This has been a long recognized phenomenon, okay? And the fact that these were called like hysterical dumbness here, people couldn't speak and sometimes hear, or hysterical seizures where they would look like they're having epilepsy and thrash around on the ground, or hysterical paralysis, reflects then the historic situation at that point, that through the 19th century in particular, there was this phenomenon that was called hysteria, which if you know any Greek, you will know refers to something that's unique to woman. And it was recognized, but, and here's the key thing, it was always thought, you see, in the 19th century, that it was just kind of weak-willed women who were prone to getting these kinds of things. Strong men didn't get these kinds of things. Hysteria, as the term, was a female phenomenon. So yes, women, they would become paralyzed when they were stressed, and they would suddenly not be able to talk and do things because they were stressed, and they would say, ooh, she's hysterical. And it was dismissed as a kind of female condition in a very unhelpful and pejorative way. And of course, in using this language, I'm not saying that women's weakness means this, etc. The point here is that you suddenly had all these strong, mentally, physically robust men who were getting exactly the same kinds of hysterical phenomena. And that was a surprise for a lot of doctors, because they thought, well, hang on, this isn't supposed to happen. What's going on here? There's nothing wrong with these men. They should be able to walk. They should be able to talk. What's going on? And there was a strong refusal. I mean, some of these poor people were executed and everything for cowardice. There was, a refusal in the armies to recognize what was going on, that the horrific stress was such, if you remember that sort of balance, so there are people who are more vulnerable with like normal levels of stress in society, would be tipped into these kinds of problems, these features of psychosomatic illnesses, including the more extreme ones like paralysis. But now under severe stress, in the war, in the trenches, even people who were much stronger, much more robust physically, mentally, would be tipped over as well. And that's what I meant when I talked about a breaking point. Any of us with sufficient stress will be decompensated. So some of us are constituted by the Lord stronger in these ways. We're not so prone to react like this to stressors. We have our other failings and weaknesses, but these aren't our particular failings. And then there's other people who are weaker in that sort of way, who are prone to react to stress at a lower level. But the point here then, the reason for this is to make the point that shell shock reveals very clearly that everybody has a breaking point or a tipping point and can be tipped over into even these most severe, striking manifestations of psychosomatic illness, because they were very clearly psychologically driven. So in his biography of Dwight Eisenhower, Stephen Ambrose, the American historian, talking about Eisenhower's life and his campaign in Sicily then, and George Patton, as some of you may know, was one of the American generals in the Second World War who served in the Torch campaign and then in the campaign up through Sicily into Italy. And when they were fighting their way through Sicily, then Patton visited a hospital, a field hospital. And he found then in the hospital a man with no physical damage to him. There were men lying there with obvious physical wounds, head injuries, limb injuries, and so on. But this man looked fine physically, and Patton, looked at him and said, "What are you doing here?" And the man said something like, "I can't cope, my nerves." And Patton, lost his temper with this man whom he regarded as a coward, a weakling, who was, as he saw it, kind of copping out, too cowardly to fight like the real men. And he slapped him in front of everybody and treated him very badly. And that caused actually Eisenhower huge problems, because he kind of needed Patton as a great general, but this was appalling behaviour he couldn't tolerate, and I won't go further. But the point here is, Patton was somebody who was clearly a very strong, robust man himself, and like so many, he couldn't understand how anybody wasn't like him. I mean, he didn't have any problem with the fighting and all the risks that it involved to life and limb, and seeing people, blown to pieces and shot and everything around. It didn't affect him. But this man had been tipped over into, a psychosomatic illness where he couldn't cope. And Patton, like so many then, was failing to recognize that we all have breaking points. We all have vulnerabilities. And this man was not faking it. He wasn't malingering. He had broken down. He had been broken by the stress of the war. And that's what we all need to recognize. Some people have lower breaking points. They break with what we might regard as fairly normal things. But that's how they are. And we shouldn't condemn them, because that's how the Lord has made them. They're vulnerable. We want to support them and sympathize with them, not, like Patton, condemn them. Just because I've been made strong enough, or you've been made strong enough to cope with these things, doesn't mean everybody is strong enough. And it isn't a moral, when I'm saying strong enough, I'm not making a moral judgment. I'm not saying these people are more inferior or anything. They have strengths and qualities that those of us who might be stronger in this way don't have. They bring other things, as we say, to the table or the party, whatever language you want to use. So we all have different qualities that the Lord's given us that we bring, and that's important to recognize. So that's my kind of overview of psychosomatic illnesses. So we're all got vulnerabilities. We can all be pushed into these kind of illness syndromes by stress. For some people, it needs to be more severe. For some people, it's more regular. But we all have these vulnerabilities. These illnesses fluctuate. They manifest in these different syndromes as we describe them. They are real in the sense of being physical, but they're also real because they're mental, and mental is real too. They're psychosomatic. But at the heart of these illnesses, if you like, in people who have them, is anxiety. Anxiety is core to these illnesses, which is why I've kind of brought these together, really. I want us to understand these broader features in these illnesses, but also then anxiety, which is kind of at the core of them. And stress is roughly the same as anxiety. Stress is kind of lay term, if you like. So anxiety, when we use it, we can mean, like I've said with depression, we can mean a symptom of that mental tension. Or we can mean a syndrome, or different syndromes, which are clusters of anxiety symptoms. And stressors, which can be physical stressors, like in the war, which are also combined with mental stressors, can precipitate anxiety. And of course, anxiety is a normal physiological response to such stressors. All of us have experienced and do experience anxiety, because that's how the Lord has made us to respond to threats. When we are threatened, made fearful, and extreme anxiety is fear. So anxiety at its extreme becomes fear. When we're threatened, we have an anxiety or a fear reaction, sometimes called fight and flight, where you get a range of responses then to the threat. And threat to ourselves then precipitates these. And this is normal. Okay, so we have these normal features. And anxiety is kind of profound physical pain, sort of a mental pain that's very physical for some people in its more severe form. Just like depression, in its more severe form, feels actually very physical. Which, and it's that language again. By saying that, I kind of in danger of giving in, as it were, and saying, well, actually, physically, some are more. But what I'm trying to get is the intensity of it. The intensity of the mental pain that you get with anxiety, and it's horrible. I mean, anxiety, you experience it, and you imagine just having that 24/7. Fluctuating, sometimes worse, sometimes better, but never away. It's horrible. So here's some symptoms of anxiety that I took from a textbook, okay? And, there's not much, there's not many symptoms that you can't explain as due to anxiety, if any. So, all sort of bodily organs, every part of our body can be affected by anxiety, and symptoms anywhere can be generated by anxiety. Hence the large range of features here I put down just to illustrate this. But I say this is just lifted from a standard book. It isn't exhaustive. So it doesn't leave anything else. And the important thing here is, a lot of these, as you see, are things that we might call physical. Sickness, vomiting, sweating, muscle aches, cough. We tend to think of these things as physical, but they can all be produced by anxiety. Now, one thing on a kind of individual level is to recognize that we all have our kind of own pattern of the way in which we express anxiety. So I know with myself, I get some chest pain. And sometimes I get some abdominal discomfort and pain. But I get those when I don't feel anxious. And that's one of the things that's quite difficult for people to understand. You think that if it's due to anxiety, I must feel anxious. I must have that sense, that feeling of mental anxiety. And without that, then this chest pain or this muscle ache can't be due to anxiety. That isn't true. Particularly early on, if you like, or when your anxiety is coming on, the first features can be purely physical. And therefore you might not recognize them as anxiety. And so get to know your own anxiety pattern. What's your own anxiety pattern that tells you that you're feeling under pressure, that the stresses are impacting on you mentally and physically, and you need to think about pulling back a bit and getting yourself some rest and a break and so on because of these features coming on. You won't necessarily feel anxious. That will typically come in later and make it obvious to you, I hope, that what's been going on is anxiety and therefore stress driven. So identify these and aim to identify what we call the early warning ones. The first ones, like with me, my chest pain, my tummy pain, that say to me, hang on, this is stress, I'm getting anxious, I need to think about my work-life balance, how I'm going to spend my time, so I kind of ease off and manage myself. So anxiety, wide range of symptoms, physical and mental, but almost anything, if not every feature that we can have in medicine can be produced by anxiety. And that, remember, this is going back to this thing about the physical-mental split. This is not fakery. When my abdominal pain comes on and I feel a bit sick, I'm not kind of thinking, ooh, I don't want to go into work today or something, and then I'll kind of feel sick. It happens because of the stress. Maybe it's a stress of work and the workload or something. But it isn't me kind of obviously faking it and making it up. This is how I respond to the stress in life. And you will respond in your own way with symptoms, with features of anxiety. So learn to identify these. To pass to a different subject, but obviously related to anxiety and one that Christians have, is this thing about anxiety being sinful. Okay. And these are the sort of typical texts that are quoted to say to some poor anxious person that, he's being bad. Now, on a semantic level, we know that in English and Greek and so on, anxiety is used in different ways and essentially can mean different things. In Philippians 2 then, Paul writing to Timothy says, that Timothy is anxious about the welfare of the fellow Christians in Philippi. Or rather, I think the English translations have, he's concerned about those brothers and sisters in the Lord. And as soon as you translate it as concern, then you feel comfortable. But when you translate it as anxiety, then you think, ooh, that's not good. Yeah? But of course, I'm just saying the idea is just because something says he's anxious doesn't mean it's wrong. Okay? Because anxious can be a good thing. In 1 Corinthians 7, remember, Paul says, a man might be anxious about the welfare of his wife. But again, I think English translation should be, he's concerned about his wife. It's a good thing to be aware of pressures and problems that the people around us are having, to be concerned about those and want to help them with that. It's clearly a good thing. But of course, that's not what Jesus is saying here. It's not what Paul is saying here. They are referring to bad anxiety. I'm just making the point that just because somebody says they're anxious, just don't think, ooh, that means it's bad, okay? It's just the way we use language. Just think that might mean concerned. But there is bad anxiety or sinful anxiety. But what's the issue here in both these texts? Well, the issue is lack of trust in the Lord, isn't it? When Jesus says, don't be anxious about anything, as you know, there in the Sermon on the Mount, he goes on to talk about how we should be trusting in our Heavenly Father who looks after us and provides for us and knows our every situation and will uphold us. So don't be anxious, don't fret and worry, which is expressing a lack of confidence in the Lord. And Paul to the Philippians is saying the same thing. He's saying, look, you might look at the days ahead and think, how am I going to cope? You might fret and worry, and that's wrong, because that is a failure to rest in the Lord and commit ourselves to Him. So there is a sinful, a bad anxiety, but it's directly related to this failure to trust in the Lord. But there's also then anxiety that's generated as part of psychosomatic illnesses, okay? That's generated by stress, that is something that we all experience as normal physiological response to threats and stress, okay? And that is all these features, these symptoms I've been talking about, and that isn't a moral thing, that's a medical thing, an illness thing, okay? Now, it's possible that when you're threatened, of course, and you have your anxiety reaction and you feel the pains and you stop breathing more heavily and you feel stressed, that you will worry and fret and fail to trust in the Lord in that threatening situation. And that failure to trust in the Lord goes back to those two texts, and that is wrong. But of course, it isn't necessarily so. You can have all these features of anxiety that I've been talking about in response to threat and continue to trust in the Lord. So you can be said to be anxious and severely anxious and have these syndromes, but you're resting in the Lord. You have the horrible mental tension, you have all these horrible physical features that are so uncomfortable, but you're trusting in the Lord. So sinful anxiety, whether it's related to an illness-generated pattern of anxiety in these sort of psychosomatic illnesses, or whether it's kind of you and me in everyday life, becoming anxious because of whatever situation we're in, stress and burnout and everything, we may or may not respond by failing to look to the Lord and trust in Him. When we fail to trust in Him, that's sin. That's fretting that Jesus warns about. Don't fret, don't worry, don't be anxious about tomorrow, and so on. But it ain't necessarily so. We can rest in the Lord through the trials of these kinds of illnesses like everything else. And just something that people do raise and ask from time to time is this thing about, so when people have these psychosomatic illnesses, when they've got anxiety, when they sin, it tends to be in that sort of public way, if you like. So they're stressed and they lose their temper, they lash out, they speak rudely, and so on. And these things are visible, you see them in your family, you see them in your church. And so you think, these people are bad. And they themselves might think, they're bad. But of course, the rest of us have our other kind of, hidden sins, don't we? There are these other sins that are very bad as well. I'm not saying those things aren't sin, because I've said they are, but we need to be careful. It's that thing about the Lord Jesus worrying about judging others, isn't it? Because here we are, with our own kind of not so visible patterns of sin. We're constituted differently. He's got this tendency to generate anxiety symptoms and psychosomatic illness and then sin in this public way. But me, I don't. But I'm proud. And I scorn others, and so on. I sin. We sin in different ways. So it's just this thing about. But people themselves, when they have these, they can beat themselves up and say, I'm a terrible Christian for behaving in that way, and they feel humiliated just because it's public. And without, as I've emphasised, dismissing the sin and belittling it, nonetheless, with the context, the larger context for us all is this, isn't it? So we always need to bear that in mind. And then finally, and again, I've talked before about stepped care and supporting people. And as I think I've said before, this is like following the maker's instructions, getting the basics right for people to start with. So engaging people and supporting them, sympathizing with them, seeking to understand these anxiety symptoms and not condemn them, because that's their particular constitution and their vulnerability in the way they respond. Supporting people to engage in useful activity, not necessarily paid work and so on, but useful activity that gives all our lives value. Support them in that. They might not be able to carry the whole load, especially when they're really struggling with their illness, but they can do something that helps. So try and find some sort of support for work. And of course, regular patterns of eating, regular patterns of exercise, fresh air and everything. These are all the sorts of things that people haven't been able to do properly through COVID, of course. Lockdown, stuck in the house, not eating properly, abusing alcohol, people around and about us not sleeping. All these things are going on around us. Keeping it regular structure through the day with your sleep, regular time slots. Yes, obviously, avoiding substances that can be unhelpful as a way that people do use alcohol and other stuff to try to treat their anxiety. Alcohol is helpful for treating anxiety in the short term. It's obviously not helpful in the long term, but that's why people do it. And again, that's a vulnerability that you can encounter. It's understandable because it's a kind of real treatment, if you like, but it's not a helpful treatment in any ongoing way.